It is my pleasure to introduce our next speaker, Dr. Daniel Thuillier. He's a foot and ankle orthopedic surgeon here at UCSF. He earned his medical degree and completed a residency in orthopedic surgery at UCSF as well. He completed a fellowship in foot and ankle surgery at Harborview Medical Center, part of the University of Washington healthcare system. His interests include ankle stability, post-traumatic ankle arthritis, and ankle replacement surgery. He's a Bay Area native. Kudos to you.
Thank you.
And currently serves as team physician for the Oakland Roots.
Thank you all. Appreciate the opportunity to talk. I love following an Olympian. It's great. So today we're going to appreciate Rhonda's talking about kind of the chronic stress injuries, which are incredibly important, can be really challenging to treat. My job will be to talk a little bit more about the acute injuries and hopefully providing a framework for how you can think about them and kind of what to do, when to refer, the ones that you should worry about and the ones that will generally be okay. I do not have any disclosures for this talk, unfortunately. So we're going to talk about incidence, anatomy, ankle sprains, high ankle sprains, ankle fractures, physeal fractures, and if I'm talking really fast, we'll get to Liz Franks just because I like to include them. So in thinking about ankle injuries, the incidence is incredibly high. There's about 600,000 ankle sprains per year in the US. There's about 2.95 for every 10,000 athletic exposures in high school. The greatest incidence is in women's and men's basketball. Women's is about 5.4, men's is about 5.1. And just for reference, this is about 10 times the rate of ACL injuries. So I'm not saying this talk is more important than Dr. Pandia's, but and as with so many things, the rate is really increasing according to our NATA data. Ankle fractures are the most common injury to be taken to the OR by an orthopedic surgeon. So though they're far less common, they can be really serious. And it's about 187 per 100,000 person years. So my wife's giving me a hard time for this slide because I include it in almost all my talks, so I apologize if you've seen it before. Anyway, this is a mortise. So anyone who does woodwork, this is a mortise joint you can see here on the right side, and the ankle is thought of to be as a mortise. The ankle is really a highly congruent joint, which is really resistant to cartilage injury until that congruence is interrupted. So under normal circumstances, very low rate of arthritis, other problems, but with injuries, these small shifts in the talus can really have devastating consequences for long-term health of the ankle in terms of pain and function. We know this from some really kind of classic study. This is a classic study in our orthopedic literature, which showed that a 1 millimeter shift in the talus changes the joint forces by about 40%. And this has actually been replicated in more recent studies that kind of show this. This is from Thorderson more recently, still not that recent, but more recently, has really demonstrated this is really true. And we see this. So this is not my patient, but this is a young woman who had this fracture. This is a high fibula fracture with the syndesmosis injury. We'll talk a lot about that in a bit. This is her initial post-surgery film. I don't have her injury films, unfortunately. Here you can see broken screw, as often happens with syndesmosis. They removed that screw, thinking that's going to be helpful. Here she is following along. They removed the hardware on the outside because she continued to have pain. Again, going back, revised the syndesmosis because was worried that it wasn't quite where it needed to be. Revised it again, moving along. You see this ankle is just now going in. So this is a 19-year-old with this injury, and then 5 years later, she's got end-stage arthritis. So this can progress really quickly if these aren't treated properly and well. So what are the contributors to a congruent joint? Well, the bones are a big contributor, the lateral malleolus, the medial malleolus, and the posterior malleolus. Note there's no anterior malleolus, and that'll be important later. And the ligaments. And for stability of the ankle joint itself, the big ligaments are the deltoid ligament medially and the syndesmosis ligaments laterally that help hold the fibula onto the tibia distally. Here's a beautiful dissection that was done by a group in Spain, I believe, looking at the parts of the syndesmosis, and you can see the ligaments here and their bony attachments. Note that those syndesmosis ligaments are just above the joint, And what we'll talk about quite a bit next, the ATFL and the CFL, the common and sprain ones, are actually below the joint. So that's what we're going to get into now, ankle sprains. I would bet I shouldn't say almost everyone, the vast majority of people here have sprained their ankle at some point in their life, especially if you've played any kind of sport. They are incredibly common. The ATFL is the most common ligament injured. It resists anterior translation of the talus, so it doesn't function in holding that mortise together. And so when you're standing, even if your ATFL and your CFL are completely out, the joint will be well aligned and the cartilage will find its corresponding spot on the other side. And that is really kind of crucial for how we think about these injuries. The ATFL is most common. The CFL, which does talar tilt and really resists eversion when you're at a neutral position, is the most commonly injured. And we often will grade these injuries as 1 to 3, 1 being kind of a minor sprain and 3 being a complete tear. But because of how the mortise is still intact and the ankle is still stable, even when these are completely torn, the grading doesn't have as much of a big deal as it will for, say, the syndesmosis later on. This also makes a big difference for how we treat these and how we think about these, because what we know is that 95% of ankle sprains are asymptomatic no matter what you do. So you can put them in a cast, you can do nothing, you can put them in a boot, you can put them in a splint, you can let them walk right away, you can take them off for weeks. But 1 year is a really, really long time. And so we like to look at it for our literature. We look at 1 and 2 years and say, this is great. But anyone who's waiting 1 year to get back into activity is not happy. So we usually recommend limited early mobilization. I usually recommend the cam boot for 1 week if they even need it, and trying to get them out after 1 week, 3 weeks really max, because what I've found in my own practice is the longer they stay in the boot, the longer they stay in the boot. And so getting them out and getting them moving early really can be helpful. And we really see slightly better early results with early rehabilitation. So for a lot of my young athletes, I'm getting them into physical therapy, getting them into their athletic trainers, making sure they're checking in with their athletic trainers basically right away to kind of get them going. And because this is generally stable and the vast majority of these will heal, even the grade 3s, even those complete tears, most of those will heal and be functional. Surgical repair is really reserved for those with prolonged symptoms greater than 6 months. So again, to hype on that rehab protocol, swelling control, cam walker, early range of motion, perineal and posterior tib strengthening, and a gradual return to activity as symptoms allow. That time frame can be really variable, and this can be the frustration sometimes in treating these, whereas some young athletes will get back within a day, 2 days, a week. Some will take 2 to 3 months to get back, and that is still normal and still generally able to get back. So this requires a lot of, I don't want to say hand-holding, but a lot of coaching and a lot of encouragement that, yes, it is still normal to have a prolonged recovery from some of these because they can take longer, and so there can be a decent amount of variability. When things are just not getting better, that's where surgery comes into play. And this is an incredibly common surgery just because the numbers are so high. So even if you have only 1 or 2% of these bad sprains who ever need surgery, because the number of sprains are so high, this is still the most common surgery I do in my practice. The tried and true is what we call a modified Brostrom-Gould. What it really is a augmented repair of the ligaments where you are still using the patient's own tissue to bring back, imbricate the tissue, and provide that stability that is needed so that shift is not happening in the talus in that frontal plane. This works very well. You're talking overall 90% results of getting people back to sport, and that's usually getting people back to sport in about 3 to 4 months with full recovery and strength, usually by 6. For patients who have really bad tears, and especially patients who are Ehlers-Danlos, other collagen vascular diseases that have ligaments that may not be amenable to a really strong repair, that's where we reserve the ligament reconstruction. You can see it looks very similar to what you can consider to be an ACL, and it is. It's really similar in a lot of ways. We usually use allograft and not autograft. Reason for that is really donor site pain and problems. The allograft works really well. We don't thankfully see the re-rupture rate. The re-rupture rate for all of these is really low. And then you're not taking something else that's going to be weak. You're not taking hamstring or quad or something else that you then have to rehab in addition. There's nothing I would like less than to take someone with ankle pain and also give them knee pain. All right, so what about high ankle sprains or syndesmosis injuries? And these can be really, really tricky. They can be tricky to diagnose and they can be tricky to treat. Ankle sprains, a lot of people get a good sense, and the nice part is, like we said, kind of no matter what you do, most of them get better, but there are certainly things you can do to kind of help that process. For high ankle sprains, so when we think about the syndesmosis is really composed of 3 ligaments: the AITFL, the PITFL, and then the interosseous ligament. There's some even additional breakdowns within that you can make, but thinking about it as 3 ligaments is crucial. Tearing just one of these won't be enough. In order to really get a true syndesmosis disruption to where it's no longer going to be functional, you have to tear all 3, and you have to tear about 5 centimeters of the interosseous. The interosseous goes all the way up between the tib-fib, and so it thankfully can hold. Even if the AITFL or the PITFL have injured, usually there's enough stability there. We don't think about that joint moving very much, but it does. The fibula actually has some very subtle movements. The talus is a conical bone, and so the front of the talus is wider than the back. And so as the talus moves up and you dorsiflex, the wider portion of the talus will come into the joint. That is good because it's an inherently very stable position. As you can imagine, most of these sprains are happening with a plantar flexed position, and that's when the thinner, less wide portion of the talus in the back is within the mortise. And to help accommodate this, the fibula will actually move and rotate very, very slightly. It's very small movements, but they are movements that can be helpful. So in plantar flexion, it'll migrate dorsally, it'll translate anteromedially, and it'll internally rotate slightly. And in dorsiflexion, it migrates proximally, translates posteriormedially, and externally rotates again to help allow the talus into that position. And remember, the function of the syndesmosis, it really helps maintain the congruity of the tibio-talar joint by maintaining the position of the lateral malleolus. So if this is disrupted, it can be really problematic because that mortise is gone, just like that image I was showing of that 19-year-old and the disruption of syndesmosis. This can be a real problem. So how do you diagnose a sprain? When we think about this and we're calling a syndesmosis sprain, what I'm really meaning is injury without full tearing to where the mortise is disrupted. So if the mortise is congruent on our imaging, it's a sprain. So basically, if the talus is remaining in place, we'll list it as a sprain. And if it's truly disrupted, though, that's another big problem. So another one, not a adolescent, unfortunately. Thankfully, I don't have any adolescents with tragic stories to show for this one. So this is a 23-year-old who was playing basketball, twisting injury, originally seen outside, and the original imaging was a little ambivalent. Got ankle x-rays, showed a little widening of the medial clear space here, and was diagnosed with a deltoid sprain, was told to be weight-bearing as tolerated and to come back in a month. He continued to have a lot of pain, ended up seeing me when he changed insurances. I looked at this and was very concerned because my biggest concern here, of course, the mortise is not congruent. And you can see here where he's got that big shift, and that mortise is actually shifted out laterally. So this is a particular injury that can be a little bit rare and often gets missed for this exact reason. The initial ankle x-rays don't show where the fracture is here. So you can see here he's got this high fibula fracture. This is what is known as a Mason-Neuve fracture. And this is really problematic because this shows basically a full disruption of the syndesmosis with the injury energy exiting proximally. And you can see not only, if we look back here, you can imagine he has a syndesmosis injury, he also has a deltoid injury. So both his deltoid and his syndesmosis are injured here. He has a fibula fracture, but that fibula fracture doesn't matter. What we care about are the ligaments that are holding that joint in place. So for this reason, this became surgery. This isn't one you can rehab and get back. This is one you really need to make sure those ligaments heal. And so the surgery we do for this that Tua Tagovailoa made famous, and many other people have had since, are this tightrope surgery. I've kind of switched away from screws and gone to tightropes for nuanced reasons I don't have time to get into. But they have been good and effective. The biggest key here is to maintain that mortise. I actually saw this guy recently, and he's back playing basketball, and he's really quite happy. And so thankfully it worked out well. All right, so what about non-disruption, the high ankle sprains? And these are where it gets trickier. Obviously, those were pretty obvious x-rays, and there's a really obvious path to take here. High ankle sprains, you want to think about pain out of proportion to the injury, prolonged recovery, pain posterior to the fibula, obviously pain that goes up the leg. The ATFL and the CFL we know are kind of below the joint. These are higher injuries. Pain with dorsiflexion of the ankle. And why is that important? Remember that the dorsiflexion of the ankle is bringing the wider part of the talus up in, and it will actually push on the fibula. So as you push on the fibula, if your syndesmosis is strained, that will cause pain. And this is more typically caused by the dorsiflexion and external rotation, not exclusively, but you can see here as you're bringing it up and you're pulling that foot out to the side, it can strain those ligaments. And so you see this injury here on, unfortunately, one of my gunners. But this is a very common mechanism when you see this. You can still get this with your typical kind of plantar flexion and inversion too, though. So don't think that it's completely separate. Diagnosing this, again, can be a little bit tricky, and so there's a number of physical exam maneuvers you can do. The most common and probably the best one is what's called the squeeze test, listed here in B. What the squeeze test does is you're actually squeezing the tibia and the fibula proximally to the ankle joint, and a positive test is when they have pain that shoots down into their ankle. This is fairly sensitive, but not very specific. I also, as a result of that, will do multiple. The dorsiflexion external rotation test, which is kind of listed here in A. Again, what you're doing is dorsiflexing the foot, having externally rotate, and what you're trying to do there, again, is straining that syndesmosis. And then this test in C, where you're having them kind of cross over to the side and doing the same thing. You're dorsiflexing, externally rotating them. I will often have these people try and do single leg heel rises in clinic as well. All of that to kind of get an idea of how that feels. One thing you can do with a single limb heel rise, which I've done, is you can get, if you have athletic tape, you can have them do the single limb heel rises, see how they feel, and then you can really, above their malleoli, tape them really tightly and have them do it and see if it feels better, and that can sometimes be helpful for you. The difficulty with that is you have to tape them pretty tight. So it can be helpful if they're getting back on the field sometimes too. However, usually you have to tape them really tight and it can be problematic. So again, all these in combination, the tenderness, the squeeze test, really specific, not terribly sensitive. Tenderness, sensitive, not specific. So I will use a combination. I'm not doing one thing and relying on it. I'm doing 3 or 4 tests and trying to get an idea of what to do. Rehabbing these high ankle sprains, everything just kind of takes longer. So you're still doing swelling control. Usually I do a cam walker. If I really suspect a syndesmosis injury, I will have them in the cam walker longer, usually on 3 to 6 weeks. I will have them do an active range of motion immediately, but again, perineal and post-tib strengthening and stabilization. These typically will have a more delayed return to activity than your just straightforward ankle sprains. All right, so moving on to ankle fractures. Again, incredibly common and an incredible variation. They usually will involve both bones and ligaments because these are usually twisting injuries. And remember that it's both the bones and the ligaments that are really crucial for providing the stability of the ankle joint. And so while we look and we see the bones, we always have to be thinking about those ligaments that are providing that stability or helping provide that stability. So all right, so how do you know if it's stable versus unstable? Well, the same thing, right? You get strained or stress x-rays and see if that talus is shifting or not. So stable will have no shift of the talus. It's usually kind of either the medial or the lateral malleolus only, and the ligaments, the deltoid and the syndesmosis are intact. For the unstable, the talus will shift. These are usually bimalleolar or trimalleolar fractures, and a combination of bone and ligamentous injuries, so the deltoid and the syndesmosis. As we saw earlier in that Mason-New fracture, it's a high fibula fracture, so just the fibula, but 2 ligaments out, and those 2 ligaments out provide an unstable scenario. The only way to truly assess stability is with radiographs. You want to just make sure that mortise really should be pretty similar all the way around. There is, of course, an anatomic variability, though. And that can sometimes be a little bit tough if things look a little weird. You can, if you're able, sometimes get the other side. Unfortunately, insurance sometimes pushes back on that, but you got to do what you got to do to best treat your patients sometimes. One common thing that we'll get is what's known as a gravity stress view. Most emergency departments and radiology technicians will know how to do this, which is just kind of hanging the foot over the side. And what you're doing is allowing that kind of external rotation. What we're really looking for here is, again, that deltoid and that medial clear space to see if that opens up. A deltoid ligament that's torn will cause an unstable scenario. An unstable scenario is not good, as we talked about earlier. I think I've harped on that enough. So for stable fractures with no Taylor shift, the gravity stress views, standing x-rays, or manual stress testing, if those are fine, even though there's broken bones and maybe injured ligaments, these can generally be treated non-operatively, where you can usually let them weight bear right away, again, because they're stable. It usually means a boot, sometimes a walking cast, for a period of time, usually 4 to 6 weeks, until they're able to have enough stability again and healing within the initial bones to then get back to kind of more normal activity. For unstable fractures, when the mortise is unstable, that's not a situation you want to leave alone and allow to its own designs, because these sometimes will heal, but if they heal in a bad position, as we said, 1 millimeter shift in the talus can lead to devastating consequences. So these typically need surgery. We do not typically address the ligaments directly. Usually what we're doing is fixing the bones and allowing the ligaments to heal themselves. The deltoid ligament and the syndesmosis, as long as the bones are lined up well, will heal themselves with good regularity and good reliability. All right, so what about for our younger adolescents? Because there's a wrinkle that always gets played in, and that's the physes, right? So the physis, as we've talked about, is where endochondral ossification is occurring. It may represent a weak point, with the ligaments now being stronger than the bone is. And so the same type of mechanisms in our patients with closed physes, with open physes, may cause different patterns. The tibial physis is the second or third most injured physis, depending on what you're looking at. So it is quite common. And all physeal injuries have the potential for growth arrest. And I think it's the next slide. Apologize. So not going to harp on Salter-Harris fractures, but you can really see any injury pattern going through the physis. The added wrinkle here always is you have to think about ligaments, you have to think about the malleoli that are protecting the stability of the joint, and then you also have to think about the physis, and so you have an additional wrinkle. Physeal closure in the ankle goes through a little bit of an interesting pattern where it starts centrally, spirals medially, and then comes back laterally. The age of closure for girls is usually 12 to 16 and boys is 14 to 19, but obviously there can be some variability within that. As a result of this kind of unique way that the tibia closes, you can create some unique transitional fractures. And transitional fractures are fractures that are happening during physeal closure, where you're going to have part of the bone that the physis is closed and part of it is open. One of the more common ones that we're seeing in the ankle is what's called a Thuillier fracture. And the Thuillier fracture happens, that is the last part of the distal tibia physis to solidify. And that AITFL is a very nice and stout ligament. And so as a result of this, it will actually pull off a piece of bone there. Obviously, we can see here you have two things to deal with. One, the physis that's interrupted, and the joint itself. In our transitional fractures, because the physis is already closing, we worry a lot less about the physis and a lot more about the joint, because as we can see, the growth is usually there. But depending on if this is displaced or not, this can really represent an unstable action. Another really kind of common one we talk about is this triplane fracture. Again, similar type of pattern. This is where you get this kind of complex pattern weaving through. You can see where here the joint is stepped off, the growth plate is off. Again, more concerning about the joint. So you get these kind of unique patterns within these ankle injuries, and they're important to kind of recognize that physis provides yet another kind of wrinkle in the stability mix because of its relative weak bone relative to the ligaments that can be really stout. So in terms of treatment of these distal tib-fib physeal fractures, one, the first treatment goal is restore the physis to their anatomic position, restore the articular surface to anatomic position, restore stability of the mortise as in adults, prevent growth arrest or angular deformities, especially for people that have, 3 or 4 more years of growth left, and then again, prevent that post-traumatic arthritis. So for the non-displaced and the stable ones, you can treat it a cast. For the displaced and the unstable, they usually need surgery. All right, so sometimes this is obvious, but what about the kind of less obvious ones? And then when do I need imaging, which often comes up. So when we talk about sprains versus fractures, again, sprain, you have acute twisting injury, pain and swelling at the ankle, bruising, difficulty with weight bearing. Fractures, acute twisting injury, pain and swelling at the ankle, bruising, difficulty with weight bearing. The only real way to tell is with imaging, but as my wife will say, who's an athletic trainer, you can't always get imaging, Dan. Can't always get imaging. And I say, you need imaging. Social medicine in Canada, I'm sure you guys have heard this. So the Ottawa ankle rules. The Ottawa ankle rules are a good framework to think about, right? So what are they? Basically, pain over any bony prominence or difficulty with weight bearing, they should get an x-ray. When you think about sprains, remember that the ATFL, you can't really palpate the CFL because the CFL is below the perineal, but you can palpate the ATFL. So pain that's directly in the anterior part of the fibula oftentimes will be the sprain. Pain posterior, pain going up, pain over the navicular. We talked about a little bit about navicular stress fractures, base of the fifth. These are all ones for whom people should get imaging. And when you look at the Ottawa ankle rules, they'll say, oh, we didn't miss or had very few missing of significant injuries. But there are things that get missed. What get missed? Lateral process of the talus will get missed. Anterior process of the calcaneus will get missed. And these are ones for whom, if they get missed and aren't kind of treated properly, can lead to long-term problems. Large OCLs will get missed. And these are sometimes ones where, if it's large enough, can be amenable to early surgery. It's another complicated topic, no time to go into, but that's where the imaging is there. Obviously, depending on where you are, depending on where you practice, these are the choices we all have to make about who needs them, especially if you're in a resource-limited environment. But when at all possible, it can be really helpful. And the Ottawa ankle rules have been validated in people with open physes and in kids, again, showing these quote-unquote significant injuries. But I love how they considered significant injuries greater than 3 millimeters, when I've been harping this whole talk that greater than 1 millimeter is a problem. And so, I know an orthopedic surgeon, but if you can't, get imaging. So what about the classic difficult one, these non-displaced Salter 1 type injuries versus a sprain? How do you diagnose these in difference? And the answer is it's hard, for lack of a better term. So again, pain that's lateral or posterior, then you would worry more about that injury to the physis. Pain that's anterior and more distal. The ATFL and the CFL actually are distal to the physis a little bit. Then you would worry more and think, maybe it's a sprain. This used to be, I think, a little more prescient because we really wanted to treat these with a cast, but there's at least some newer data that shows even a functional brace or a boot, these non-displaced Salter-Harris type 1s do just fine. And so that may make it less of an issue where you can just kind of immobilize them for a short period of time, regardless. All right, I have yet to talk about really CTs or MRIs. And that's because most of these you can diagnose without having to go there, but there is a time for advanced imaging for sure. And you should consider it if for any unclear or suspicious x-rays. And honestly, if you have fracture lines that are going into the joint, you probably should get one. You can see where that triplane can be a little tough, but the lateral really shows the step off. And sometimes you'll have patients who just have unexplained symptoms. It'll be going on, they'll have a sprain. Usually for me, a sprain that has pain lasting beyond 8 weeks. With initial normal x-rays, I'm getting an MRI, again, to look for OCLs, other things that might be continuing to give them problem. And obviously there just comes a time when your suspicion is just high, and your imaging is not there, and that can be helpful. And so, as we all see patients over time, that subconscious pattern recognition kicks in sometimes, and you want to say something here is just a little not right. And so sometimes we just got to do that. So in summary, ankle injuries are incredibly common. I'm sure most of us have seen them and a lot of us have had them. Ankle sprains are obviously much more common than fractures. Ankle sprains do better with earlier rehab, so try not to just lock them up and say, come back later. Try to give them a program or get them into physical therapy quickly, get them to see their athletic trainers, get them going. Imaging is usually the only way to truly distinguish sprains from fractures. So if you are concerned, try to get imaging. Physeal injury about the ankles are very common, and you really do need imaging to kind of understand if it's displaced, is it stable, where it is, and what's going on. Maintaining the physis in the mortise is a real key to a stable and functional ankle and one that will last a long time. A lot of these injuries, despite how bad they might look initially, if you can get the physis back, if you can get the mortise stable, it'll be a good ankle for a long, long time. All right, thank you, and as always, go Roots.